Hello, my name is Nathan, and I'm going to talk to you today about my PICOT question regarding palliative chemotherapy. I work in an acute care unit with oncology focus, and chemotherapy is a big part of the lives of many of our patients. And so, as we look at our patients, I have always been interested in what dictates quality of life. So, oftentimes, when our patients come in with a new diagnosis, the oncologist provides a curative treatment, which makes sense. Their goal and their purpose is to cure cancer. As the nurses, we then administer this treatment, and our whole focus is to help them hopefully go into remission and live long, happy lives. This, unfortunately, however, isn't always possible. Some people opt not to receive any sort of curative treatment, whether it be chemotherapy or radiation. Some people, due to the state of the disease process, curative treatment may not be effective. And so we need to be able to present palliative care options and end-of-life care to all of our patients, because frankly, they all need to know the different treatment options that are available to them. So I chose to look at historical evidence and current evidence on palliative chemotherapy versus curative treatment. And so my question is, do patients with a terminal cancer diagnosis who receive palliative chemotherapy rate their quality of life higher than those who forego palliative chemotherapy during the last 6 months of life? For the research process, I used HEALWALL and searched palliative chemotherapy, and then had to narrow it down and include palliative chemotherapy versus best care treatment versus curative chemotherapy, and various searches to come up with research that actually rated quality of life. In total, I reviewed about 10 different articles, and of those 10, only about 4 really met the criteria that I was looking at. So from that review process, the research done on palliative chemotherapy and quality of life is somewhat lacking. One of the difficulties lies in the various cancers and the number of cancers that exist. Different patients are going to respond differently to different cancers. Different cancers are going to have different treatment. We need to look at the stage of the disease process, the age of the patient, and the overall health before diagnosis. So with those factors in mind, however, the research that I did review drew similar conclusions that palliative chemotherapy increases quality of life. So dating back to 1997, studies have shown that patients who receive palliative chemotherapy over curative chemotherapy for gastric cancer had improved and or prolonged quality of life. Other studies have found that palliative chemotherapy leads to longer periods of time in between the last dose of chemotherapy and end of life, and there are also more referrals to hospice care for those who receive palliative chemotherapy. And hospice care has been shown to increase quality of life for patients. So also, many patients will live longer on hospice care than curative treatment. So that, however, is going to vary by disease. And the other study, patients were, in order to qualify for the study, patients had to already have been receiving palliative chemotherapy for 12 months previous to that. So this study, they discussed how they were able to focus on living life, focus on relationships and the people around them, and they were able to express contentedness and happiness and fulfillment despite receiving chemotherapy. And the last study that I reviewed basically suggested that during palliative chemotherapy, the symptoms are very manageable. So it allows patients to have that increased quality of life due to better symptom control. So there are, of course, limitations in these studies, and there are biases. Sample size is an issue. No sample is greater than 150 patients, and in one of them, the sample was only 20 patients. In that particular study, they also knew the researcher because it was administered at a cancer center, and so that alone could influence the patient's perspective and their willingness to express negative side effects related to symptom management like nausea and vomiting. So we have to remember that there are some limitations here. There is, however, clinical significance. We do have to recognize the qualitative nature of any data that's going to refer to palliative chemotherapy. The majority of the research is based off self-reported data from patients, and we have to acknowledge that different patients are going to have different factors that influence what they perceive as high quality of life. Despite those differences, all patients need to be made aware of their different treatment options. In some cases, curative treatment is the best option and outcomes are really good. In other cases, curative is not recommended. In either circumstance, the patient needs to be presented the palliative treatment, the curative treatment, and the outcomes, projected outcomes, so that they can make an informed decision. They can't make an informed decision if they're not given these options. So, seeing that there's limited evidence, it does, however, suggest that there's an increased quality of life with palliative chemotherapy. So, this needs to be brought up with each patient. It's going to require oncologists and nurses alike to have very frank, but also very loving conversations with their patients and with families and loved ones so that they understand what's presented in front of them. And sometimes the very best treatment, the very, very best cure, the very best fight of the patient isn't enough. And so we have to understand that and recognize that situations are going to change and opportunities to discuss palliative chemotherapy will come up potentially later during the patient's care. So I would love to see all oncology nurses trained in palliative chemotherapy and some sort of course or research that they could review so that they understand the benefits of palliative chemotherapy. So they need to know these things so that they can be confident when having these discussions and talking about potential projected outcomes and typical outcomes regarding palliative chemotherapy. So in order to spread this knowledge, there's a couple things that we can do. We can have increased collaboration with the palliative care team. They can hold forums where they discuss palliative care regarding chemotherapy and best treatments for end of life. And they can work in collaboration, the palliative care team, with the oncologist to ensure that they're providing best treatment, blending the two specialties. So along with the forums, online classes could be developed in order to have a resource that's always made available for the nurses to access at any time. Ultimately, we have to have a change in culture where we shift from only pursuing curative treatment to including the palliative regimen and making sure that the patient's able to choose. So from personal experience and the experience of several nurses on my unit, oftentimes palliative treatment is not provided up front, and only the curative option is provided to the patient. And these views are narrow. It's myself and other nurses from a single unit, but we just need to take that into consideration because this unit is where we want to make the change. So it allows for us to have increased focus on where can we step in, where can we make change to make sure that our patients can make informed decisions. So I also suggest that we have a change agent, which would be a nurse who voluntarily is knowledgeable and up to date on palliative treatment options and has experience with having these conversations with patients where they can review cases of new diagnoses, make sure that the patient understands that there's different options available to them, and they're willing to teach other nurses how to have that discussion. And how to read the family and read the patient, looking for statements of frustration with recurrent hospitalizations or symptom management, statements of hopelessness, and those are all cues that we can use for appropriate times to have this discussion about palliative chemotherapy. So I believe that oncologists have the initial responsibility of bringing this up with the patient, but then the nurses are going to follow up, and it's their responsibility to ensure that the patient understands what's been presented to them. So following the change agent every single quarter, perhaps during staff meetings, we could have a review of patients who've chosen palliative chemotherapy versus curative, and we could do our own research study over 6 months, say, where we use a already provided scale that patients can then rate their quality of life, and we can do this with all of our oncology patients, and then use that as a comparison and as a base when we move forward to talk to new diagnoses about their care. Ultimately, we need to focus on how many patients are presented with this option, not so much how many choose it or how many choose not to. And as we increase knowledge about the benefits of palliative chemotherapy for our patients, that's when we're going to see a difference, and that's when we're going to hopefully see our patients having an increased quality of life, because ultimately we want them to live the best life that they can live. So thank you for your time, and I hope that we can continue to see change and improve the lives of all the patients that we care for. Thanks.